We're going to look at the Zika virus. It's an emerging teratogen, and we were looking at teratogens in week 2, and I would like to add some new information about the Zika virus. The Zika is a single-stranded RNA virus. It's a flavivirus. It's closely related to dengue, yellow fever, Japanese encephalitis, and West Nile viruses. It's transmitted to humans primarily by the Aedes species mosquitoes. The modes of transmission, mosquito, as well as it can be passed from the mother to the fetus. It can be an intrauterine infection. It can be sexually transmitted. It can be transmitted from a blood transfusion, from a laboratory exposure, and theoretically, it could also be passed by way of breast milk or an organ or tissue transplantation. Now, the species of mosquitoes that carry this virus are the Aedes aegypti or the Aedes albopictus. It's the same mosquito that's responsible for the transmission of yellow fever in the 1900s and dengue and chikungunya in the current age. They lay eggs in domestic water holding containers. They live in and around households, and they are aggressive daytime biters. The fact that they bite during the day is something that most people don't realize. They always think that the mosquitoes come out at. Here we have a map, two maps, showing you where we find these two different species of the Aedes mosquito. And you can see that the Aedes albopictus goes all the way up into New England here. Let's look at some of the precautions that you should take for mosquitoes. You need to cover your exposed skin by wearing long sleeve shirts and long pants. You need to use an EPA registered insect repellent containing DEET. Pregnant and breastfeeding women can use all EPA registered insect repellents, including DEET, according to the product label. Most repellents, including DEET, can be used on children aged over 2 months. You can also use permethrin treated clothing and gear such as boots, pants, socks, and tents. And you need to stay and sleep in screened in or air conditioned rooms. These are just some of the countries that are currently reporting Zika. Many of these are holiday destinations. The Zika disease. The incubation period is about 3 to 12 days. You have a viremia that lasts about a week, but it can last longer in some people. The scary thing about this disease is that 80% are asymptomatic. The clinical illness is usually mild with symptoms lasting for 2 to 7 days. So it is a mild disease. And one of the things about this mild disease is that if you take a look at the symptoms and take out conjunctivitis, it's so much like any other viral disease. And we sometimes will say, oh, you have flu-like symptoms. The mild fever, the skin rash, the joint pains, the muscle aches, and the headache. This is a disease that even when it's severe, it's uncommon to require hospitalization. And there's a low case of fatality. Some of the serious outcomes, though, are the Guillain-Barré syndrome and other neurologic. First of all, I'd like to say that even if you have microcephalia, it does not mean that you have um, any type of intellectual disability. But there is varying severity that can occur with microcephalia. There are those that have seizures, developmental delay, intellectual disabilities, problems with movement and balance, feeding difficulties, hearing loss, and vision problems. In pregnancy, there's limited information about the Zika infection. However, existing data do show that there's no evidence of increased susceptibility. Infection can occur in any trimester, although we do believe that if it occurs in the first trimester, just like with other infections, that there is more damage. There's no evidence of more severe disease for the mother, and sexual transmission is by way of the semen. With severe microcephalia, we have the skull that actually becomes partially collapsed. There's decreased brain tissue with a specific pattern of brain damage associated with the pterogenicity of the Zika virus. The central nervous system effects include lissencephaly, ventriculomegalia, and cerebral calcifications. Now, the damage is such thing to the eye is where you have to the back of the eye, you can have scarring and you can have pigment changes. Joints can have limited range of motion, and a club foot could also um, form. Too much muscle tone is also found, which can restrict body movement soon after birth. One other scary thing about this virus is that some of the babies are born and they don't have microcephaly and they don't appear to having in a neurological involvement, but these babies develop this at a later time. So when we look at the Zika virus disease cases in the United States, we can see that there have been about 5,505 symptomatic Zika virus disease cases reported, and of those, the majority are in travelers returning from affected areas. There were like 225 cases acquired through the presumed local mosquito-borne transmission. And then we also have 50 cases that were acquired through other routes, including sexual transmission, laboratory transmission, and person-to-person through an unknown route. In the U.S. territories, we've seen approximately 37,062 symptomatic Zika virus disease cases, and 147 of these cases were returning from infected areas. When we look at pregnant women with any laboratory evidence between 2016 and 2017, we've seen that in the United States, in the District of Columbia, it's been about 2,197, and it is double that in the U.S. Territories. And we have a Zika active pregnancy surveillance system. The outcomes for completed pregnancies in the U.S., the District of Columbia, and the U.S. territories are being looked at. Completed pregnancies with or without birth defects, 1,901. Live-born infants with birth defects, 98. And pregnancy losses with birth defects, 8. The brain or abnormalities with or without microcephaly that have been seen and what you need to watch out as a health care worker is confirmed or possible congenital microcephaly, intracranial calcifications, cerebral atrophy, abnormal cortical formation, corpus callosum abnormalities, cerebellar abnormalities, poor encephalia, hydroencephalia, ventriculomegalia, hydrocephalia, excluding mild ventriculomegalia with or without other brain abnormalities, fetal brain disruption sequence, collapsed skull, overlapping sutures, prominent occipital bone, and scalp rugae. I have slides of that you're going to see in just a moment that show you the scalp rugae and the prominent occipital bone. There are other major brain abnormalities which can also come about. So if we look at some of the other things that have been included here is the neural tube defects and other early brain malformations have occurred, neural tube defects, structural eye abnormalities, and the consequences of central nervous system dysfunction can occur because you get these contractures that occur because of the muscles being so tight. And then there's also congenital deafness that has been documented by postnatal testing. This is a picture showing you the normal head size and what a child with microcephaly looks like in comparison. And we also see that every time a child goes to for a well baby check or is checked, the head circumference is one of the hallmarks that is always done. And we also see that when after the baby's born, it is also done. This is showing you the scalp rugae and the malformed skull. Again, you see this in this baby. the club foot, and how the you have the baby's flattened head on in the picture here because of the collapsing of the skull can be noted. Again, you can see that here. Let's look at the guidelines for pregnant women as of September 2017. For pregnant women who are asymptomatic, they do not have a primary symptom with an exposure, um, and guidelines do not recommend testing asymptomatic pregnant women unless the fetus has congenital Zika syndrome, CZS. With pregnant women who are asymptomatic with an ongoing exposures, i.e., they have to keep traveling down to areas that have the virus, or they have had unprotected sex with a traveler to an affected area, the guidelines recommend PCR testing of urine and serum at first prenatal visit and at 2 subsequent visits if exposures cannot be avoided. As of September of 2017, when we're looking at infants, normal pre and postnatal exams for those infants and the mother was exposed during gestation and tested negative or was not tested, the guidelines recommend that you do not do routine testing of healthy infants. In the case of non-pregnant patients, preconception testing of women with ongoing exposures can be done to establish a baseline IgM. And when we look at the newest guidelines, they do not recommend IgM testing for this purpose. For asymptomatic exposed patients, the guidelines do not recommend testing asymptomatic patients. This is a Zika virus report form for the state of Connecticut. The current CDC guidelines on travel are if women who are pregnant in any trimester, they should consider postponing travel to any area where Zika virus transmission is ongoing. If you must travel to one of these areas, talk to your doctor first and strictly follow steps to prevent mosquito infection during your visit. If you have a male partner who lives in or has traveled to an area where Zika transmission is ongoing, either abstain from sex or use condoms consistently and correctly for the duration of your pregnancy. Women who are trying to become pregnant, before you or your partner travel, talk to your doctor about your plans to become pregnant and the risk of Zika virus infection. You and your male partner should strictly follow steps to prevent mosquito bites. Now, if we look at the Zika virus infection in pregnancy and the clinical management of such, positive or inconclusive Zika virus testing results antepartum. If you were to receive these, consider serial ultrasounds every 3 to 4 weeks. Referral to maternal fetal medicine specialist is also recommended. In postpartum, histopathologic examination of the placenta and umbilical cord should be done. Comprehensive physical examination, including head circumference, hearing screen, and developmental assessments need to be performed. And need to consider further evaluation, head ultrasound, and ophthalmologic assessment. And you should consider testing infant specimens. If you are definite that it's congenital microcephaly, for live births, the head circumference at birth would be less than the 3rd percentile for gestational age and sex, or if the head circumference at birth is not available, the head circumference is less than the 3rd percentile for the age and sex within the first 2 weeks of life. For stillbirths and elective terminations, the head circumference at delivery is less than the 3rd percentile for gestational age and sex. Now, if you're looking at possible congenital microcephaly, for live births, if earlier head circumference is not available, the head circumference less than the 3rd percentile for age and sex beyond 6 weeks of life is used. For all pregnancy outcomes, microcephaly diagnosed or suspected on prenatal ultrasound in the absence of available postnatal head circumference measurements is a possible congenital malformation, congenital microcephaly. And here are some resources to look over.